Good evening, everyone. Good evening, everyone. Hi, everyone. Okay, thanks for joining. There's quite a few that's come on board. Thanks, guys. Thanks for joining. We're just gonna wait for Dr. Sulaiman to join. Sing some well-known names here. And Fertility Collection. Hey Charles. Okay, so I'm just gonna wait for Dr. Sulaiman Heylen to join us. Thanks everyone. It's been a while. It's been a few weeks since we had a talk, and so I'm almost feeling like I'm nervous, like I haven't done this in a while. So trying to conceive Cape Town. Thank you for joining us. So Dr. Sulaiman is there. So fertility talk today again. We're talking about PCOS and infertility. I'm just gonna accept Dr. Go live. Dr. Sulaiman Heylen from the Cape Fertility Clinic, neofertility specialist. Thank you for joining. Dr. Heylen, how are you, Dr. Heylen?
I'm fine, Leanne. How are you?
I'm good, thank you. Always nice to have you.
Thank you.
And I think whenever I say Dr. Sulaiman Heylen is going to be joining us, everyone is very excited and everyone just shows up. So thanks everyone for always being here when Doctor's talking. And we've got quite a few questions for you. If you guys have any other questions, please put in the comment section. Dr. Sulaiman is always, Dr. Heylen, sorry, is always happy to answer your questions. So we're going to talk about PCOS and infertility. It's a topic we do quite a bit, but the reason why is because there are so many women that is suffering with PCOS, and it's like every time we do a talk, it's a whole new lot of women that is joining us, as maybe just been diagnosed with PCOS and so forth. So thank you very much, Doctor.
You're welcome. And thanks for inviting me. It's always a pleasure to be with Fertility Solutions.
Awesome. Maybe you just want to take a minute or two to introduce yourself to those who don't know you.
Okay. I work at Cape Fertility. I am from Belgium, but I've got a South African wife. I am in Cape Town for the last 25 years, but I trained fully in Belgium. So I'm a medical doctor, I'm a gynecologist, and I'm what we call a specialist in reproductive medicine. That means we do fertility treatments at Cape Fertility. We are 5 doctors and we do full-time, nothing else, and trying to help couples to have babies. I'm also the president of what is called SASRE, which is the South African Society of Reproductive Medicine and Gynecological Endoscopy, and that also keeps me quite busy.
Yes.
And my passion is in fertility. It means trying to help women and couples that can't have babies to fulfill their dreams and to have a baby.
Awesome. I saw your post the other day with holding a little baby that was recently born as well. And it always just melts your heart when you see that. And I'm sure you get very excited to see these babies, that all these couples that you help.
We see everyday patients sending me pictures or emails or WhatsApps of their babies or thank you messages, and it's really a very, very nice job that I have.
Awesome, doctor. So I'm going to get right into the questions. First of all, what is PCOS?
Well, PCOS is a very bad name, huh? I think that's the most important thing I would like to tell the ladies today. So polycystic ovarian syndrome, that's probably the worst name ever for any medical syndrome, because it sounds horrible, eh? If you say cysts from the ovary, everybody thinks, oh, I've got cysts from the ovary, I must be operated. I think about maybe horrible consequences like cancer or something like that, but that's not true. Polycystic ovarian syndrome has nothing to do with cysts. It's just a disease from the ovary, and it's like a metabolic disease or like an endocrine disease, and you can better compare it to something like diabetes than to a cyst. So in the past, doctors didn't know anything about polycystic ovarian syndrome, and they looked at these ovaries and said, oh, these ovaries are looking full of cysts. But these are what we call follicles. What is that? A follicle is basically an egg factory. It's a structure in the ovary where the egg must develop. So women with PCOS have got lots of follicles in the ovaries. And the thing is that the signal in the body doesn't work properly, and therefore these follicles don't develop properly and the egg does not come out of the follicle. So it's basically a problem where the follicles do not develop and the women do not ovulate. So that's basically the bottom line of PCOS. It's an endocrine disease, it's a hormonal disease from the ovary that makes that women do not ovulate properly. And it's by far the most common cause of ovulation disorder. So there are other ovulation problems, but 90% of all ovulation problems is nearly caused by polycystic ovarian syndrome. And that's something that is so common. Some studies even say it happens in up to 10% of all women. Is something that is seen at the fertility clinic virtually every day. So polycystic ovarian syndrome, PCOS, is a disease from the ovary where women do not ovulate. And that's a nutshell. It has got nothing to do with cysts or nothing to do with cancer or with surgery or something like that.
Okay. How is PCOS diagnosed?
Yeah. There is something what we call the Rotterdam criteria. And that's basically a definition on how we diagnose polycystic ovarian syndrome. And for polycystic ovarian syndrome, these are the three criteria. The first one is women have a problem with the ovulation. So how can we know if there's an ovulation problem? If there's a problem with the menstrual cycle. So a normal menstrual cycle is around 4 weeks, give or take a week. So between 3 weeks and 5 weeks, so between 21 and 35 days, according to the books, is what we call a normal menstrual cycle. But in cases with polycystic ovarian syndrome, that doesn't happen. That means the cycle becomes irregular. And most commonly, the period stays away for a while. So if the period stays away for 2 months, 3 months, then we call it a problem. Then it's called an abnormal menstruation caused by an abnormal ovulation. Some women with polycystic ovarian syndrome, when they start the period, they have prolonged bleeding. So they don't bleed for 5 to 7 days, but 7 days, a week, 2 weeks, 3 weeks, 4 weeks, and they keep on bleeding sometimes. So one of the most common symptoms, how we diagnose polycystic ovarian syndrome, is with an irregular period, which is caused by a bad ovulation. So that's the one, an abnormal ovulation. The other thing is an increase of male hormones in the body. We call it an increase of androgen. And the one that we all know is testosterone. So a male hormone is normal for a woman to have. A man has female hormone. A woman has male hormone. But obviously, in men, the male hormone levels are higher. In women, the female hormone levels are higher. So there must be a normal amount of male hormone in all women. That's what they're supposed to be. But in women with polycystic ovarian syndrome, there can be an increased amount of male hormone. And that increased amount of male hormone we can detect with blood tests. So we can do blood tests, so we can take the forms, send you to the pathology lab, and we can see it. But it can also sometimes be expressed, and we can see that by just looking at the woman, because it can have symptoms. And the most common symptoms are acne, okay? And a lot of women with polycystic ovarian syndrome do have acne. And we shouldn't confuse it with a teenage acne, I think. So a lot of young women, when they're 15, 16, 17, 18, they've got some kind of acne, which is quite common. But typically in women that are a little bit older, and it becomes quite severe. And the other symptom that we see, the other skin problem that we very often see in women with polycystic ovarian syndrome is hair growth, abnormal hair growth. So hair where they are not happy with. On the face, on the chest, on the breast, on the abdomen, on the arms, on the legs, so that you can see there is an excessive amount of hair growth. So that's number 2. Number 1 was the bad ovulation with an irregular period. Number 2 is the increased amount of male hormone that can be measured or that we can see in clinical symptoms. And number 3 is what we see on an ultrasound. So if we do an ultrasound, we can do an abdominal ultrasound, but typically we do a transvaginal ultrasound. So we put a probe in the vagina and we check the uterus and then the ovaries. And in the ovaries, we see a lot of these little follicles. And these follicles, they must be there. That's normal. Every woman has got follicles in the ovaries. But if you see too many of them, okay, if you see on both ovaries a lot of these little follicles, then we say, okay, this ovary has got the morphology, has got the impression, or has got the ultrasound sonographic aspect of polycystic ovarian syndrome. So now we come back to the Rotterdam criteria. What has it to do with the with Rotterdam, with the city in the Netherlands? Because all the clever doctors came there together and said, okay, now this is how we're going to diagnose polycystic ovarian syndrome. And they decided it has to do with no ovulation, with the increase of male hormone, and what you see on the ultrasound. And that's how we diagnose polycystic ovarian syndrome. But yes, very often we can diagnose it clinically, because these women, they come and they tell we've got very bad periods, they've got skin problems, and then it has also got other associated problems, like the very common one, the weight gain. We will speak about it, I'm sure, a little bit later. So very often we can diagnose polycystic ovarian syndrome without doing blood tests and without doing an ultrasound, but we can expect it just from the history and from doing a physical examination of the patients. Yeah.
Okay.
Does that answer it?
Yes, very much. That's a very good answer. I actually remembered that one. So yeah, that is absolutely perfect. And I'm like, as you go through it, I'm always ticking off. Yep, I got that. Yep, got that.
Yeah.
Definitely. There's a big one. Is there a cure for PCOS? The reason why I say it's a big one is because a lot of women will say, oh no, I'm cured, or there's a cure, you can take this medication and that medication for it. So I'm going to ask you, doctor, is there a cure for PCOS?
Yes and no. Really, actually not, because you must see it as a chronic disorder, like asthma. Okay. So if you're diagnosed with asthma, and you say, okay, you've got asthma, it's not going to go away. It might get better, it might get worse, but it is very well manageable. And that's the same with polycystic ovarian syndrome. So if you got polycystic ovarian syndrome, it's a disease from the ovary, not your fault, you're born with it. Okay, that's what it is. Okay, so you're born with the disease. Now you have got the polycystic ovarian syndrome, and it's not going to go away. Now, sometimes the expression of polycystic ovarian syndrome can go away or can become more serious. I'll give an example. If you pick up weight, then there is a better chance you will have symptoms of polycystic ovarian syndrome. So I've heard this story very often, that women come to me and we diagnose them with polycystic, with PCOS. And then I ask about the period, and I said, my period was always regular, doctor, until I got married. And since I got married, my period is becoming more and more irregular. Now, why is that? So then I asked, what was your weight before you got married? Yes, I was 65. And what's your weight now? No, it's 85. Because once I got married, I mean, husband and wife, you spoil each other, you make nice food for each other, you go out, eat, and life is wonderful, it's good, and pick up weight. Now, the weight gain can bring the polycystic ovarian syndrome to expression. And therefore, the opposite also is there. If you lose weight, the polycystic ovarian syndrome can become less visible. So that's why some women can say, okay, my polycystic ovarian syndrome is cured. Okay. Then I wouldn't call it cured. I would call it in remission. Okay. So if a woman, for instance, is 85 kilograms, she loses weight, and now she has got no symptoms of polycystic ovarian syndrome anymore. It's great, that's wonderful, and it's good for her health, it's good for a chance to conceive. But it's something like it's in remission, like you've got a treatment for other disease, it's in remission. And if she is going to pick up weight again, it might come to expression again. So polycystic ovarian syndrome is not something that we can cure. So we cannot say, I'm going to prescribe you these tablets and you're not going to have polycystic ovarian syndrome anymore. I wish. Huh? And that makes it so frustrating also, huh? Because in medicines, very often we can. So you come, you've got a bladder infection. So you say, okay, I've go to the bathroom a lot, it burns. I test the urine and say, okay, there's a bladder infection. I prescribe you something for 3 days, 2 tablets, one in the morning, one at night for 3 days, and it goes away. It's nearly guaranteed. It's wonderful. We can cure it. But polycystic ovarian syndrome, it's a different type of problem or a different type of monster. Huh? Because once you've got it, you've got it. And it's not going to go away. But very important, it's not a curse, because we can manage it really well by all the treatments that are available, and also by looking very well after your health, after your diet, after the amount of exercise, what you do, and you can control it very well. So it's something that you have to learn to live with. So if you've got asthma, you have problems, but you've got your pump, it can help, and in spring season, or you can have more problems. Okay, that's fine, but you can learn to live with it, and you can manage it very well. But we can't cure it. Unfortunately, I wish I could say, okay, now you take this, and you will never ever have polycystic ovarian syndrome. I'll do an operation on you, and you will never have polycystic ovarian. That doesn't work. But yes, we can help women. And the nice thing about polycystic ovarian syndrome is that actually, from a fertility point of view, it's a good diagnosis. Because if women come in my office and we find, for instance, there is blocked tubes, or there is endometriosis, I give no examples, or they've got a low egg reserve, that's the biggest problem, a low ovarian reserve. Sometimes we struggle, so we have to go to the big guns and all these things. But PCOS, it's usually not too difficult. We can usually make them ovulate quite quickly. And if there are no associated problems, most women can have quite easily a baby. So it's not, from a fertility point of view, it's not the worst diagnosis that women can have. So we can really manage it very well. But we can't cure it. I'm sorry.
Yeah. I actually love it when you say that to women, and I'm sure there's so many women smiling now. So if you're listening,
I think we have to be positive if we speak about polycystic ovarian syndrome. And I always try to be positive when patients come with this problem, with other problems also. You must be realistic, but also positive, because it's a good diagnosis to have. And when there's no other associated problem, so you've got a 30-year-old woman with polycystic ovarian syndrome has been trying to conceive for 5 years, for instance, and the husband is fine and the tubes are fine, there's a very good chance she's going to be pregnant within the next 6 months without doing advanced treatment, without that we have to do IVF. Might take a month, might take 6 months, but there's a very good chance that we will be successful quite soon.
That's awesome. That's awesome, doctor. What medical issues are you at risk when you are diagnosed with PCOS? What other medical issues?
I think that's a very important question, because polycystic ovarian syndrome, it's not just a disease from the ovary. It is a disease that's got an effect on the whole body and on the health of a woman. And it can lead to serious health consequences. The two most important ones are diabetes and hypertension, high blood pressure. And we can also ask that because most women with polycystic ovarian syndrome have got somebody with diabetes or hypertension in the family. Nearly everybody, huh? It's very common. So we ask them, how's your mom? No, my mom is fine. And your dad? No, my dad has got sugar and high blood. Okay? I always say, okay. It's very common to have these diseases in the family, and women with polycystic ovarian syndrome are at a serious increased risk of developing that. Now, I don't want to scare people and say, okay, wow, this is like a very serious. It is important, but it only happens usually later on in life. So once they are in their 40s and 50s, and also very importantly, in pregnancy. Women with polycystic ovarian syndrome are at increased risk of developing diabetes and high blood pressure in pregnancy. Fortunately, these problems we can manage quite well. So general practitioners, gynecologists, obstetricians, physicians, I mean, that's what I do. Diabetes and high blood pressure, that are things that I see every day. So that can be done, that can be managed. And again, we come back to weight. If women keep their weight under control, they can prevent, especially for sure, that they will develop diabetes and hypertension in pregnancy and also later on in life, because these are diseases that can lead to consequences, because diabetes and hypertension, although it can be managed, it has an increased risk of having things like heart attacks and strokes. And I mean, we don't want to go there. So for these reasons, it's important that women manage their polycystic ovarian syndrome very well to avoid that they're going to have these complications later on in life. There are other also potential health risks with polycystic ovarian syndrome. One is sleep apnea, so that women, and it happens also, is also very common in men, okay, that you don't breathe properly in your sleep, and that can be detected by sleep tests at a sleep clinic, and there is medical treatment for that, and you can have a machine that helps you with breathing, so there is definitely treatment for that. That's another problem. So people with sleep apnea, they go to bed and they sleep, and very often they snore, and then they wake up in the morning and they're tired, and they're tired the whole day. So that's, and if you have that, then maybe it's a good idea to contact the sleep clinic to test for that. And the other problem is, and again, I don't want to scare people, is cancer of the uterus, cancer of the lining. But it's something that's important to mention. Now, if you have a period every month, you have what we call shedding of the lining. That means the lining comes on. Now, in women with polycystic ovarian syndrome, they have estrogen, but they don't ovulate, so they don't make progesterone, and they don't have shedding of the lining. So they have continuous, people always, say, I've got a hormonal imbalance, which is correct. So there's an imbalance between the estrogen and the progesterone. They always got estrogen, 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 no progesterone. So the lining keeps on building up, building up, building up, building up, building up, building up. Sometimes then they have prolonged bleeding because the lining is slowly coming down. But in the long run, if there is no progesterone, this lining can become precancerous and a cancer of the lining, or endometrial cancer. Now, it's also not something that's going to happen tomorrow, and it's also not going to happen that if you haven't had a period for 2 months, you're going to have cancer of the uterus. I speak about a long process over many, many, many years. That's why doctors very often, when they diagnose women with polycystic ovarian syndrome, they prescribe progesterone to make sure that these women, that the effect of the estrogen is counteracted. That is, we make sure that there is shedding of the lining. So we can prescribe medication like tablets like Provera or Dufaston every month to bring on the period. Or very often we put women on birth control pills, and birth control pills is a combination of estrogen and progesterone. So that helps also to counteract that. Or sometimes we even can insert something which is called the Mirena. That's a loop that contains progesterone that can also help. Now, I would like to say quickly something about it, because women that don't have any periods for a long time, we say that they are at risk for cancer of the lining only when there is no progesterone. Because sometimes we doctors also prescribe medication that stops women from having a period, but there's always medication that does contain progesterone. So if you prescribe a drug like Visan, or if you insert a loop in the uterus called the Mirena that contains progesterone, and women have subsequently no period, there's no risk of cancer of the lining On the contrary, it actually reduces the risk of cancer because there is the progesterone is there. The progesterone takes away the risk of cancer of the lining. It's the estrogen, the prolonged estrogen in the body, which is not counteracted by the progesterone, that makes women at risk for endometrial cancer. Estrogen in itself is harmless, but estrogen without progesterone is the problem. Okay, so that's the thing. So these are the health risks, mainly the hypertension and the diabetes. And then also the cancer of uterus and sleep apnea, that are the very common health risks. Yeah.
Okay. How does PCOS affect my fertility?
Yeah. So PCOS is a disease from the ovary where women don't ovulate. So that means, and we said it in the beginning already, you've got these little follicles, these little egg factories in the body, these little round structures, which you can see beautifully on the ultrasound. They don't develop big, and the egg does not come out of the ovary. So that's the problem. There is a lack of ovulation. And it's the signal between the ovary and the pituitary gland that's not working properly. So the hormones that are coming from the pituitary gland, the LH and the FSH, and the hormones that are coming from the ovary, the estrogen and the progesterone, they don't interact properly with each other. Again, sometimes people call it's a hormonal imbalance, which is correct, yes. But I mean, it's PCOS. So PCOS causes an ovulation problem, and then women don't ovulate, and therefore, if the egg doesn't come out, you can't conceive. So the job of the fertility doctor is very often just to make women ovulate. So we always speak about weight management, and we speak about hypertension and diabetes, but then at the end we end up using fertility drugs. And we give fertility drugs, and the fertility drugs don't make a woman ovulate. And if we can make her ovulate, then she can conceive. And if the egg comes out, and there is no associated factor, so it means the tubes are fine, the uterus is fine, the husband is fine, then we can just give medication to make her ovulate. Say, okay, you're going to ovulate tomorrow. You must just have sexual intercourse, and then hopefully it will work. And hopefully 2 weeks later we can have a positive pregnancy test. So PCOS has an effect on the ovulation, and the treatment is give ovulation medications. There are many different options that we have, and we give ovulation medication to induce ovulation, and then hopefully it will work quickly.
Okay. What plan would Cape Fertility? So you almost answered that question, but I'm just going to ask it. What plan would Cape Fertility normally recommend when trying to conceive with PCOS?
Yeah. So the first consultation we speak about all the other things, about health issues and weight management and how to do things, and then afterwards we focus on making a baby. So we give fertility drugs, and we can give tablets that we have to take in the cycle. So a lot of women with PCOS, like we said, they don't have a period, so we give first progesterone, Provera, or Dufaston to induce a period. Once they start a period, the first day of the bleeding, we call it day 1. And then we start with fertility drugs, usually from day 3 of the cycle. And we give tablets, typically 2 tablets per day for 5 days from day 3 until day 7 of the cycle. There are 2 types of tablets. The one is clomiphene citrate. That's the older one. And the newer one is called letrozole. They're both given in a similar way, 2 tablets per day from day 3 until day 7 of the cycle. Both are quite effective, but there is more and more evidence that letrozole works a little bit better than the clomiphene citrate, and it's got a little bit less side effects. So we tend now to go to letrozole and not to the clomiphene citrate anymore. So we wait for a period, we induce a period, maybe with medication, then we give tablets from day 3 until day 7, and then we have to check it. So how do we check it? We do a check with an ultrasound. We do again the vaginal ultrasound, like we do to diagnose PCOS, But instead of all these little follicles, we hope to see one big follicle. It's nice, beautiful, round structure on the ultrasound. We see the follicle, and it must be now 20 millimeters in diameter, around 2 centimeters. Big, huh? Okay, so it's really, okay. This is very easily visible. What is that? That's the egg factory. That means in the follicle, when the follicle is around 2 centimeters, it contains a mature egg. And then the egg must come out, and the egg must be released. Sometimes it comes out by itself, because we start the system at work. But very often we help it a little bit. We give what we call a trigger shot. For the final maturation of the eggs, we give an injection that works like LH, and it works for the final maturation of the egg, and then it will make that egg will come out of the follicle. It will come out of the follicle into the fallopian tube, and then a woman is in the fertile period and she does ovulate. So we can say, okay, you're going to ovulate tomorrow night. Okay. You can say, take the injection at that stage, have intercourse then. Okay. And then hopefully it will work. So we give fertility drugs from day 3 until day 7. We check it with the ultrasound, okay, to see if it does work. And then we give, in the majority of the cases, an injection. And then 1 week after an ovulation, in most cases, we send for a blood test to check for progesterone. Because if the progesterone is high, then we know, okay, she did ovulate very well, which is important for the future. Because if you know this works, if you know, okay, she had a lovely follicle and the progesterone is good, but now she's not pregnant. Okay, what now? Are we not going to panic? We're just going to do it again. Because that's the nature of fertility treatment. We very often have to repeat it before we are successful. And then we just do exactly the same thing. So I always say to the patients, to the ladies who come for fertility treatment, and you must persist in the madness. You must keep on doing the same thing. If you say you keep on doing the same thing and you expect a different result, that's like madness. But it's not true for fertility treatment. For fertility treatment, it's just the opposite. If you persist in doing the same thing, in the majority of the cases, we are successful. Because we must also understand that natural fertility is not very high in human beings. It's estimated to be about 25% on average. Depends, obviously, if you're young, if you're a bit older, if you're... But if a normal woman and a normal man, if they have intercourse around the moment of ovulation, we expect in normal circumstances, that means without any fertility issues, a chance of conception of 25% or maybe a little bit higher than that. That means if we do fertility treatments and the woman has got a problem with the ovulation and we make her ovulate, what can we expect? That, 25%. That means that it is 75% that is not working the first time. And then we always ask, what went wrong? Well, nothing went wrong. We just had bad luck. And it can happen, can have bad luck. Okay. And if we try again, we can have bad luck again. But if you keep on trying a few months after each other, it's unlikely that you will have bad luck month after month after month. So if we make somebody ovulate, and we do all the checks with ultrasound, we see everything looks fine with blood tests, now we know it's working, then we know, okay, it's fine, you're not going to panic. And the same, say, if a couple say, okay, they'd like to have a baby, and the first month they're not pregnant, they're not going to contact me and say, okay, we've got a fertility issue. It's the same with fertility treatment. If it's not successful after the first month, but you do all your checks very carefully, we're not panicking, and we say, okay, we can do this again. And there is obviously a lot more that we can do. Some women don't ovulate with the tablets. Okay, what do we do then? We give injections. We give injections with FSH, follicle stimulating hormone. So the follicle does not grow. If the follicle doesn't develop, we give an hormone that stimulates the follicle. FSH, follicle stimulating hormone. And with FSH, we can virtually make any woman with polycystic ovarian syndrome ovulate. It's like virtually guaranteed, Okay, it works always. The only problem is that these are injections. So it's not nice to take an injection. and it must be done every day, and it can become quite costly, and it must be monitored very carefully. Why? Because sometimes women, they respond too much, they make too many eggs, which is also not good. So if we do fertility treatment, we like to have one egg. Why? Because we like to have one baby. Yes. We don't like to have 6, not 5, not 3, and even not 2. Yeah. Why not? Because there is an increased risk of complications in multiple pregnancies. Even in twins, there are a lot more complications than in singletons for mom, but also for babies. And not only during the pregnancy, but also afterwards. When the kids are born, they can be worried about long-term handicap for the kids, basically. That's why when we do fertility treatment, we must be careful and try to make one egg at a time. And with these injections, because they are so powerful, as I said, we can nearly guarantee that the woman will ovulate. They are so powerful. We must be very careful that we don't make too many eggs, that she doesn't have multiple pregnancies. And in the past, I mean, now we are much better. In the past, you heard it sometimes, that there's a woman pregnant so-and-so, and she had 5 or 6 triplets or whatever. It's nearly always a woman with polycystic ovarian syndrome who over-responded on the fertility drugs, and I wasn't monitored very carefully. And it still happens today that we do the monitoring, say, but this is not good. You make 7 eggs. Please sleep in separate rooms, I always say then, huh? Okay. Yeah. And then we try again next month, and we do a lower dose stimulation. We give less strong drugs. Yeah. Okay. So the treatment is tablets, and if the tablets don't work, injections. And then it's very rare, it's not common, that women with polycystic ovarian syndrome, we have to do IVF. So I spoke to you, we said earlier that the prognosis in women with polycystic ovarian syndrome is quite good. Huh? And most women can conceive without doing IVF, without using what I always say is my big gun. Huh? And IVF means the in vitro fertilization, that we take out the egg, fertilize it with the sperm outside the body, and bring the fertilized egg back. It's not common that women with polycystic ovarian syndrome need that. And it's usually, they need it if there's an associated factor. The sperm is not great, for instance, or she's also got a bit of endometriosis or something like that. Huh? Then we might need IVF. But most women with polycystic ovarian syndrome, we can treat with tablets. If the tablets don't work, we give injections. And the majority of the women don't need anything else than that.
Okay, more good news for the ladies with PCOS. Okay, thanks, doctor. Can IVF or ICSI help when you have PCOS? I think that is also something you've actually just answered.
Yes, it can. Okay, and it is in the majority of the cases not necessary to do it. But yes, if you got a woman with PCOS and she has been through lots of treatment and she's still not pregnant, or if there is an associated fertility factor, or she becomes a little bit older, she's now 38, 39, then we sometimes say, okay, now let's do IVF. Okay? Yeah. Cases like that, because obviously otherwise we're running out of time. Yeah? But it's not always necessary. And because for most of women, we fortunately don't need to do IVF, but it is an option. It's certainly an option. And IVF is virtually an option for everything in fertility treatment. It's like our ultimate weapon, and our biggest weapon and our best weapon. So we can throw it at virtually anything. If you've got PCOS or endometriosis or block tubes or a low sperm count, whatever, we can do IVF. Huh?
Yeah. Okay, so that is it. And then we've got a few questions from our audience that sent to me beforehand. If you have, I have seen other questions come through, but let me first go through these. Is amenorrhea, okay, I hope I got it right, amenorrhea and anovulation causes of PCOS?
Well, it's our symptoms, huh? Okay. Yeah. Amenorrhea means you have no period, huh? Anovulation means you don't ovulate, huh? So these are symptoms of PCOS. So a woman who's got no period and who doesn't ovulate, there's a good chance she has PCOS, because PCOS is the most common cause of these problems. But it can be something else too. Huh? So I'll give an example. It can be a thyroid problem, or can be the pituitary gland which is not working properly, or can be prolactin problems. So there are other causes also of no periods and no ovulation. But PCOS is by far the most common one. So if a woman has got this problem, there's a very good chance she does have PCOS.
Okay, perfect. The next question is, she's 39 years old. Her first baby is 5 years old, but struggling to conceive. So, obviously struggling with secondary infertility. What could the problem be?
I
Or
don't
what
know.
would you recommend she does?
I don't know. And that must be tested. So if you have secondary infertility, that's the same thing as if you got primary infertility. And sometimes it feels quite strange. I mean, I've been, but things can happen, things can change. So we have to do all the basic tests. So we start by checking the ovulation, by checking the tubes, by checking the husband, by checking the uterus, see if all these factors are there, and then we take it from there. So for secondary infertility, that's the same as for primary infertility. That means women have never been pregnant. We must just check it out and to make a diagnosis. And once we make a proper diagnosis, then we can make a plan. Okay, and it can be PCOS, because some women with PCOS, they do ovulate, maybe not every month, but every second month, and they do conceive for the first one. And then for the second one, that doesn't work, and they try for 3 years and still not pregnant because they've got PCOS. So it could be that also, but it can be very different causes for that. So secondary infertility is the same as other problems. We must test. And once we test, we can make a diagnosis, and then we say, okay, this is a problem, that's what we can do about it.
Okay, perfect. Second last one is ovulated, diagnosed with PCOS in October, changed her lifestyle, done 2 cycles of Clomid, ovulated on both cycles, 2 dominant follicles, but still not conceiving. What would you recommend next?
Persist in the madness. Okay.
I love that.
Yes. Okay.
I think I'm going to do a post on that tomorrow, persist in the madness.
Yes, because this is not abnormal. We obviously estimate that there is no other associated factor. And it would be very important just to do a basic sperm count on the husband, because that's the minimum that you need to do. Because I don't want women with PCOS to do 6 months of Clomid or other fertility drugs. And then after 6 months, you see, not pregnant, you do sperm count, you see the sperm is not good. I mean, that's like a waste of time. So that's the minimum that you need to do for any type of treatment before you start on fertility treatment, on ovulation induction, like she has said. Testing of the fallopian tubes, we usually, we stay away from that in cases of PCOS because it's not common to have these 2 problems associated. And certainly it's not a nice test. We have to send women for an X-ray of the fallopian tubes, and for some women it's a bit painful, so we try to avoid it if we can. But the sperm count is test. So this woman, she should make sure that her husband has been tested. If the husband has been tested and he's fine, try again and try again. And up to 6 months after each other. Clomid is a good drug, but like I said, letrozole is probably a little bit better. So consider going to letrozole,
Awesome. Okay, then the last question I have here is, with AMH of 3.21, what causes someone with PCOS not to produce enough eggs after stims, be it long or short protocol? Okay.
Well, I don't know, because if you say you've got an AMH of 3.21, that's not typical for PCOS. A woman with PCOS will have an AMH which is much higher than that. She will have typically an AMH above 7, 10, 12, 15, 20, okay? She will have a high. So I'm even not sure if that's the right diagnosis. Secondly, if a woman doesn't stimulate well on a certain protocol, there can be different reasons for that. It can be maybe that she doesn't have the right drug. So very often we give a medication that only contains FSH, follicle stimulating hormone, but they also need some LH, okay? Or sometimes women respond slowly and we stop too soon. We just should carry on a little bit longer and then we see it's coming. But with an AMH of 3.2, it's fine. That means, if it's nanogram per milliliter, if it's the normal values that we use in South Africa, it's fine. What does it mean? it means that there are sufficient eggs in the body. Not too many, not like typically for polycystic ovarian, not too little. That's just right. And she should ovulate. She should respond on fertility drugs. It's unlikely that with an appropriate stimulation, she will not respond. Okay, so I mean, it's difficult in a case like that. You really have to review the stimulation protocol, see exactly what's happening, do the blood test, then do the ultrasound, and do all these things, and then only we can make a plan for cases like that, because it's not something we can really answer via this media. Yeah.
Okay, I've got the last question that was posted here is, in case of someone having a blocked fallopian tube, what treatment would you recommend?
Yeah, if you've got blocked tubes, you've got two solutions. Huh? You can do IVF or you can do tubal surgery. Okay. Again, it is it depends on what's going on. Huh? So in a case like that, you have to make a correct diagnosis, see where the blockage is, see how bad the blockage is, and see if it's possible to do tubal surgery. And we do tubal surgery, we can hopefully fix the fallopian tube, and then she can conceive. So that's option number one. And option number two is to doing IVF. For IVF, we remove the eggs from the body, we fertilize it with the sperm outside the body, and bring the fertilized egg back inside uterus, so we don't need fallopian tubes. So if the tubes are blocked or not, that doesn't matter. Okay? So if a woman has got no fallopian tubes, which can also happen, we can do IVF. Okay? Because the fallopian tube, it's necessary for fertilization of the egg and the transport of the fertilized egg towards the uterus, and we can do that in the lab also. So for blocked fallopian tubes, two solutions, but unfortunately no small solution. Huh? So it's not like again, I mean, that's better to have PCOS, huh? Because PCOS, I prescribe letrozole, 2 tablets for 5 days. Okay, we check with the ultrasound, they have intercourse. Okay, that's not too bad, huh? But with blocked fallopian tubes, you need or surgery, which is a big thing, or you need or IVF, which is another big thing, huh? So there's no easy solution for blocked fallopian tubes, unfortunately. Yeah.
Okay. Well, thank you very much, Dr. Sulaiman. We actually we covered so many questions, and you covered so many things for us in this this talk. Again, thank you so much for your time. And if anyone is wanting to get hold of Dr. Sulaiman Heylen, he is at the Cape Fertility Clinic. You can get his details, or you go to Cape Fertility, the website, or you can come to our website, DM me. You can email him as well. I think it's Heylen. Am I right? It's Heylen at Cape Fertility.
.co.za, yes. SHYLN at capefertility.co.za. I always say, don't call me, email me. Huh?
Email, yeah. Doctor is very, very good at emailing. You always get a response very, very quickly. So please, guys, thank you very much again, Doctor. And okay, how do we contact Doctor? I've just given the details, but you can go to his website, capefertilityclinic.co.za. But thank you very much, Doctor, and have a great evening.
You're welcome. Thanks, Leanne, for the invitation. It's always a pleasure to be with you. Bye-bye. Take care.
Awesome. Thank you. Bye.